So my name is Kayla, and I'm going to give a presentation on concussion signs and symptoms. So we'll get started. So just first off, I do not have any disclosures. A couple of objectives that we'll go over today. So we're going to briefly define sports-related concussion and discuss a little bit about its epidemiology. And then we'll kind of get into the meat of the presentation, which is really touching on the signs and symptoms of concussion, as well as the subdomains of these symptoms. And we'll discuss a little bit how the subdomains help us target different treatment strategies for concussion, and then discuss about factors that may predispose athletes to longer recovery times. And then one of my favorite things to kind of chat about a little bit as a physician is the role of imaging in concussion. So we'll talk about that. And then I'll end with a couple pearls before I leave. So what is a sports-related concussion? So big picture-wise, a sports-related concussion is a traumatic brain injury induced by biomechanical forces. And so this was agreed upon in the consensus statement of concussion in sport. Most concussions that are sports-related share several common features, either being a direct blow to the head or an injury transmitted where forces are transmitted elsewhere. This usually results in rapid onset of short-lived impairment of neurological function that does eventually resolve. And the acute signs and symptoms that happen usually reflect a functional disturbance, and these are not a structural disturbance in the brain. The result is a range of clinical signs and symptoms that may or may not involve loss of consciousness. So you do not need to have loss of consciousness to be diagnosed with a concussion. So more on a micro level about concussion. So after you have this direct blow or injury that has forces transmitted elsewhere, such as like a whiplash injury, there's a cascade of like neurometabolic events that do occur in the brain. There's a number of things, but some of them I listed here. You have potassium efflux from cells, you have depressed neuronal activity, depletion of intracellular energy reserve. You can have decreased cerebral blood flow, which we see on fMRI scans. You have impaired oxidative metabolism. There's no real like significant amounts of cell death, which I think is important to understand. I had a mentor in fellowship who talked with patients about concussion as when you sustain a concussion, imagine your brain is like a bowl of cereal and all the cereal spills out and all those pieces are kind of all over the floor and your brain's kind of working hard to put them all back into the bowl. And sometimes that gives patients a little bit of idea what might be happening on this micro level. Okay, so we'll talk about epidemiology briefly, only because we don't have a lot of information on it. We have some, but it's kind of difficult to obtain at times. So as most of you know, 44 million youth participate in sports annually, and this number is probably a little bit even outdated. It's getting more and more each year. And there's around 1.1 to 1.9 million sports-related concussions occurring annually in kids under 18. And there's many challenges, like I said, in obtaining the true epidemiology of sports-related concussions, mainly because there's a lot of underreporting. There's a lot of athletes who don't report symptoms when they happen. Athletes touch base in different areas of like the care system. So there's school nurses, there's athletic trainers, there's physicians, there's parents, and I think like we don't have the full picture, right? The high school sport with the highest risk of concussion still remains American tackle football. For female athletes, though research is pretty limited, we're working on it, but it's much more limited. Soccer still carries the highest risk. And we see sports-related concussions incidents much higher in competition than in practice. So what does a concussion look like? So I always tell my athletes right when I see them, I don't have a test that can tell you have a concussion. I don't have a blood test. I don't have a picture. But what we call concussion is a clinical diagnosis. And you have the mechanism of energy and you have a constellation of symptoms that kind of follow. If you have a clinical suspicion for a concussion, it's really important to remove that athlete from play immediately. And we'll talk briefly about the assessment, but ideally that assessment should take place in a quiet area off the field once you're kind of sure about the ABCs. So, airway, breathing, circulation, and kind of make your assessment in a quieter place so you can really understand what's going on with the athlete. The provider who's making that assessment, one of the biggest toolboxes that they most often use is called a SCAT-5. And I included that in this presentation because I think it's important to just, if you've never seen one, to take a look at one and know what the trainers and nurses or coaches are doing on the sidelines when they're seeing those athletes. So this is kind of a little bit piece by piece of what the SCAT looks like. So step one is really looking at these red flag symptoms. And I'll go over these again in the presentation because I think they're really, really important to know. But red flags of an athlete who's with a suspected concussion include neck pain, like cervical spine tenderness, seizures, loss of consciousness, deteriorating sense of consciousness, vomiting, being agitated or combative, worsening headaches, any numbness, tingling in the upper extremities or lower extremities, and visual changes. The next step is to kind of, in the SCAT, is these observable signs. What do they look like on the ground? Are they like in the supine position? Are they in the prone position? Are they stumbling off the court? Are they saying nonsense? Like, what do their eyes look like? So all these things that you can kind of look at right away. And then the step 3, there's a couple questions, right, that the provider is kind of supposed to ask right on the sidelines as far as quick memory assessments. And then always considering your GCS, your Glasgow Coma scale, and then doing your C-spine assessment. Typically, then, once you've established that this, you've kind of crossed off your ABCs, everything's looking okay, the rest of the exam and assessment should really take place off the field if possible. At this place, you're kind of gathering athlete medical info, any history of concussions. Are they taking any medications? Do they have any medical conditions that you need to be aware about? And then on the right here, you see the symptom evaluation. And this is just kind of going right down the list. How do you feel, and kind of filling this out accordingly. And then there's also a portion of the SCAT called the cognitive screening. And there's a bunch of kind of questions at memory and like months of the year backwards, numbers. So those kind of assess different aspects of the cognitive screen. And then the neurological exam should be completed. And this includes a balance test, which I think you guys are going to be talking about later in this session. So when I'm doing a neuro exam, there's some key components that I tend to look at kind of by system. So looking at the autonomic system, it's always good to get a set of vitals. So you want to check their blood pressure and heart rate for sure. Do a very careful pupil exam. You may see pupil dilation. You may see some orthostatic hypotension. When you're doing the eye exam, this may exacerbate their symptoms, which is pretty common. And then as far as doing your eye exam, you're looking at their vestibular symptoms, convergence. Are they tracking appropriately? And especially in the acute period, these are most likely going to be abnormal. And then as far as, looking at vestibular signs as well, you're looking at their gait, doing tandem gait. Are they able to stand up straight? Are they swaying? And again, this could also, like when they turn in their head, this could also exacerbate some of their symptoms. And like I said, I'm going to refer back to these red flags because as you're doing the SCAT, these red flags may come like later. They might not be present initially on the field. And so there's something you always need to watch out for, because if, the athlete's becoming more combative or losing consciousness or worsening vomiting and worsening headache, these are all red flags that they should be evaluated in the emergency room. So the signs and symptoms can be kind of categorized into different subdomains, and this can help us target certain treatments as far as what the athlete is endorsing like more symptoms for. So there's the somatic subdomain, the vestibular, some refer to it as oculomotor, cognitive subdomain, mood and emotional, as well as sleep. And then you can see how the symptoms in this chart here kind of fall into those categories, and it kind of helps, like I said, guide treatment. And I think it'll become a little bit more clear in the next slide here. So for our somatic symptoms, so headache's definitely the most common symptom you're going to see in a concussion, followed by dizziness and inability to concentrate. So for our headache symptoms in this somatic dysfunction, one of the mainstays of treatment that we really recommend is light aerobic activity. And I think, that's where a lot of the education can come in, because when I was growing up and, there was a head injury, we were always told, oh, go in a dark room, turn off all the lights and don't come out till you're feeling better. And we really know that that's actually not going to help the athlete, and it could actually hinder their recovery. So I think I spend a lot of time educating patients on the somatic symptoms and how they can get better with aerobic exercise. And usually I'm recommending about 15 minutes of stationary bike, treadmill, walk your dog if the light isn't bothering you, walk around the track at school. If you have an athletic trainer that can supervise this at the beginning, I think that's really helpful. Again, this is all sub-threshold light aerobic activity. So if this is worsening symptoms, then they need to take a break and give it a day and try it again. The next kind of domain of symptoms is the visiovestibular dysfunction. And this is kind of more the headaches associated with dizziness, nausea, also probably some neck pain in there. And for these types of symptoms, if they're coming in with a lot of dizziness, a lot of difficulty tracking, I'm usually pulling out the vestibular therapy card pretty quickly. And hopefully you'll get a little bit more about that later in the day with some of our awesome physical therapists. But I think that's been really helpful for kids to start that really early if we're seeing a lot of pathology in that area. The next area is cognitive dysfunction, and that includes like a big one, which is difficulty concentrating. And I think a lot of times something that especially the parents are super worried about at the beginning. And so when we're approaching that, it's really about this like return to learn plan. So I go through school accommodations with athletes, like how can we help them? Do they need to wear sunglasses in school? Do we need pre-printed notes? Do we need extra time? With my collegiate athletes, I'm telling them like, let's study for 15-minute intervals, take a 20-minute break and study again. So I think it's, developing a kind of a specific return to learn plan is really important. Like, are they in band? Do we need to figure out, easing them into that? So I think that's kind of athlete based, but really important to consider. And then as far as mood, anxiety, depression, irritability, nervousness, so these can all be exacerbated, especially if they have underlying anxiety or mood dysfunction. And certainly, if these symptoms are persisting, recommending counseling or something is also part of the treatment strategy. And then sleep dysfunction. Again, usually it's trouble falling asleep, I find, but if they're having lots of awakenings or just really, really tired during the day, the first thing I try to do for athletes is really say, like, we got to cut out naps because most of them are napping, and we got to have a normal sleep-wake cycle. So we work on that first. I very rarely use melatonin if we, need it or the patient's already on it. I'm certainly fine having them do it, but I really try with just basic sleep hygiene recommendations at the beginning. So as I kind of mentioned during this, there are certain factors that may predispose these athletes to having longer recovery. And I think it's really important to address these with families when you're setting expectations for recovery. So I always ask like a lot of medical questions in my interviews to determine if any of these factors exist. So having number of previous concussions and then having concussion symptoms that are already lasting longer than a week can predict longer recovery rates in athletes. There are definitely studies that say a high initial symptom burden. So when they fill out that symptom sheet, if it's super, super high, that can also predispose an athlete to longer recovery. And then there's like a mixed bag of things. Some studies show that female sex, high cognitive symptom load, a loss of consciousness, and young age can also increase the risk from prolonged recovery. But this is, like I said, it's kind of, there's different papers that say different stuff, especially in the female population. So as far as these examples of these pre-existing kind of factors in both intrinsic and extrinsic that can affect recovery that I ask about. So we always ask about any history of ADHD or any learning disabilities, as that can really affect cognitive symptoms. As far as the vestibular symptoms, do they have any ocular dysfunction at baseline? Do they have strabismus? Do they have, are they wearing glasses? All those types of things can worsen symptoms or make it longer for them to recover from that standpoint. A lot of my POTS patients have a lot of difficulty with the vestibular system after a concussion, as well as like the mood and anxiety symptoms. These can be really, really exacerbated in patients who have underlying mood disorders or mood dysregulation that's maybe not treated appropriately, or even if it is treated appropriately, can have exacerbations of this. And then baseline sleep issues, if, they at baseline, like I said, are on melatonin or on a sleep aid, that can be exacerbated as well. As far as imaging, I think this is probably Besides the when can my kid get back to sports question, this is probably the most popular question I get is, hey doc, do we need a CT? Do we need an MRI? To diagnose a concussion. And again, we talk about how a concussion is not going to be diagnosed by these. CTs and MRIs are going to be used and ordered to rule out other things. So we're not using them to diagnose a concussion. You may be familiar with what's called the PCARN criteria. So this is what usually emergency rooms use to determine if a head CT is warranted following head trauma. And so it's kind of divided by age. So you have the 2 years in an older crowd and the younger than 2 years. And you can see kind of the flow chart here that helps providers determine if a CT is necessary. Obviously, like given cost, radiation, we don't want to be ordering CTs on every patient who comes in with a head injury. So this has been really, really helpful, I think, for emergency room physicians and providers to determine if an athlete or individual needs a head CT after trauma. Really, a CT is looking for acute, severe intracranial injury. We're looking for acute bleeds. I'll get asked like, oh, should we get a CT like 2 weeks after the event? It's not going to help us really at that point at all. So I think that's important to also educate patients about. Now imaging later on, such as an MRI. So I think those can be helpful to assess for structural problems that may mimic concussion symptoms. And certainly you may have an athlete who had some sort of structural abnormality in the brain, got a concussion, and now we're seeing, now some of the symptoms aren't exactly adding up. And certainly those do warrant additional imaging. I had a patient, an athlete in fellowship who I believe he was 10 or 11, he just got hit with a football in the head. It was not a big trauma. And all of a sudden he just starts vomiting and loss of balance. And he was wearing a helmet. It was very minimal trauma. And the athletic trainer was just this is not right. Something's weird. So they sent him to the emergency room. He got a CT, no bleed, everything looked okay. And then he followed up with us and we're doing his exam and he has really significant clonus and really hyperreflexive in his lower extremities. And so that again, and then this history of just vomiting, this light trauma, something's not adding up. So this is a kid who needs additional imaging. We ended up getting an MRI of his entire spine and brain, and he had a huge Chiari malformation that just happened to be discovered because he, kind of got tipped over by this concussion. So there's a place for imaging, but it's not to diagnose a concussion. It's when you have this underlying suspicion that something else isn't right. And we need to figure out, what the structural abnormality is. And then before I kind of close, I always just want to end with a couple pearls. So as far as concussion, I think that what I end my visits with always is, if you ever have symptoms, stop playing. And then for the providers that are on the field, for parents who are watching their kid, if you ever see a head injury, pull that athlete from play, and don't send them back in the same day. I think that's just really, really important. And if I tell my parents, if you learn anything from this clinic visit, this is what I want you to take home. And same with the athlete. That's, if they continue to play, which a lot of them have, and, they got hit, they continue to play and they come in, I'm okay, that's, you're okay. You're going to get better. But next time, pull yourself out and hopefully we avoid a longer recovery or worse symptoms or something worse that can happen if you got hit again. The other big pearl is know the red flags that prompt evaluation in the emergency room. And we went over those. Use your provider toolbox. If you're on the sidelines, your SCAT-5, your symptom scale. I always tell parents average recovery for a concussion in an adolescent can be anywhere from 2 to 4 weeks, but everyone's different. Again, push that light aerobic subthreshold activity right at the beginning. Can really help, especially with those somatic symptoms that we talked about. And then, athletes shouldn't be cleared to resume activity until they've completed the stepwise progression back to sports. And that's really, really important. And we have, the boots on the ground, the athletic trainers are helping us do that, but not every school is fortunate enough to have that. So I try to make sports specific ones and give them to parents as a little guide to follow. But if you, have access to, there's some of those exist online too. I would, encourage you guys to also have that in your back pocket so they have a good idea of how to get back safely. And Like I said, I work at the Children's Specialty Care Center down in South County. I do see concussion patients every Monday, Tuesday, and Wednesday. We have like a dedicated time slot for them, so I can give them a little bit more time than the average musculoskeletal complaint. So if there's ever a concern, I'm happy to see the patient. We usually do recommend waiting at least 48 hours from the time of the injury before they're coming into the clinic. And then my partners, doctors Tara Blatnick and Mark Halstead, also see concussion patients at their respective locations. If you guys ever need someone to see your athlete, we're happy to. And then I've listed some of my references here. Yeah, questions?
If you have a child that is suspected of concussion, would your first line of research be to the pediatrician, or would you recommend sending to someone such as yourself?
That's a great question. I think it depends on the comfort of your pediatrician. Where I trained, we did a lot of education for pediatricians to feel confident in doing a concussion evaluation and caring, especially at the beginning period. And if it's like they're recovering great and they're back to school in like, a week to 10 days, then, I think that's fine. I think if the pediatrician is comfortable, then I think it's a great, because they know the patient, they know the family. But I also have a lot of pediatricians who are really hard to get into. And I also have a lot of parents who want a little bit more education on the concussion. Maybe they, a little bit more concerned about returning to that activity. Or if it's a little bit more prolonged, I think pediatricians tend to want, a specialist to take a look. But I would say if the pediatrician is comfortable and you call their office and you can get in and you're more comfortable seeing someone, I don't think it's a wrong move. I've noticed I've been practicing here in St. Louis for 2 years, and I've noticed a couple of groups who do take care of concussions and do a great job. We've shared our return to learn plans with a couple of groups, so they have access to those accommodations. But certainly I don't think it's ever a wrong move to talk to your pediatrician first. And I think they'll be very honest if they're comfortable or if they want to refer. Yeah. So it just depends on if symptom wise, really. So like with that one patient, like I got it right away because he had symptoms that weren't matching with a concussion. Most, like I said, most concussions we should see recovery in like 2 to 4 weeks. If they're really prolonged and not improving and we're stagnant and plateaued, I think, imaging can be helpful to rule out other things. I think it's a low suspicion if other things have been fine, like such as their clinical exam and everything. But I wouldn't say there's a specific time point. It's more symptom based. Yeah. Any other questions? And then I don't know how to check the Q&A if there was anything online, but maybe not.
I think Lynn had been
monitoring.
watching that. So
Okay.
Yes,
Good.
we did not.
Okay. Well, thank you guys.
I want to thank you very much for your presentation today. Certainly set the framework for the rest of the day.
Awesome.
Would like to thank you, the token of appreciation from the Brain Injury Association of Missouri.
Thank you guys. It was great to be here, and thanks for inviting me.